So today, let's discuss about anti-diabetic drugs, their mechanism of action and the side effects. But before that, let's understand what diabetes itself is. Diabetes can be classified into two main categories. One is diabetes type 1, the second is diabetes type 2. In diabetes type 1, there is absolute deficiency of insulin, whereas in type 2, there is relative deficiency of insulin. So diabetes is a condition in which diabetes mellitus specifically is a metabolic disorder which is characterized by hyperglycemia. So if too much glucose in blood, it will come out in your urine. So glycosuria also, and there will be excess lipid deposition by this glucose, and there is going to be a negative nitrogen balance, and sometimes may lead to ketonemia. Right, there will be changes within the kidney's basement membrane. There is going to be proliferation in the vascular components, and there is going to be narrowed lumen of the blood vessel. Having said this, let's talk about what diabetes 1 is specifically. But before that, let's understand why is all these blood vessel issues happening. Because there is going to be growth, or there is going to be proliferation of the vascular components. Right, there's going to be cellular proliferation, the matrix proliferation. After all of this, there is going to be enhanced non-enzymatic glycosylation of tissue proteins due to persistent exposure to high glucose concentrations, and that is going to lead to accumulation of larger quantities of sorbitol, a reduced product of glucose in tissues, and are believed to be the causative and the pathological they are responsible for the pathological changes in diabetes. Having said that, so the concentration of glycosylated hemoglobin, that is HbA1c, is taken as an index of protein glycosylation. That term needs to be underlined. The protein glycosylation is the reason, or is what we consider HbA1c as, and it reflects as the state of glycemia over the preceding 2 to 3 months. It's almost like a long-term mentioning or long-term assessment of the glucose concentration. Now, in the first type of diabetes mellitus, there are two types, that is 1A and 1B. 1A, there are autoantibodies against the beta cells of the pancreas. Now, they're detectable. So that's when you say this is a type 1A type of diabetes, right? Now, this diabetes is also called as IDDM, that is insulin dependent diabetes mellitus. So I told you, right, it's absolute deficiency of the insulin. But there are other conditions where there are no autoantibodies, but it's still an absolute deficiency of insulin. That is the 1B subclassification. And this is going to be idiopathic basically. Right. Now, type 1 conditions are the ones which lead to ketosis usually, right? And the fact that there is decreased degree of genetic predisposition. There is nothing like, okay, this might have come up through genetically. But what we are more interested in is in the type 2 type of diabetes. Type 2 diabetes mellitus is pretty interesting because, as I've already told, it's relative deficiency of insulin. But the catch here is that there are two mechanisms mainly. One is that the beta cell receptors are messed up, right? At the level of pancreas, the beta cell receptors are messed up, and because of which they have a higher threshold for glucose, ultimately leading to beta cell failure. Second is the fact that there is decreased sensitivity of the peripheral tissues to insulin. That basically means peripheral tissues will need more insulin to, absorb glucose. Then lastly, the number of receptors for insulin itself decreases. Right, and type 2 diabetes is the kind of diabetes which we always look into in the society, where there is late onset when the person is already old, past the middle age, and these are like the 90% of the cases. Fun fact here is that most of the people who are having hypertensive conditions, they're hyperinsulinemic, but they're normoglycemic. What does this mean? So the blood glucose levels are normal. If the person is hypertensive, the blood glucose levels are normal, but his insulin status within the blood is pretty high, right? So, and they have associated dyslipidemia, hyperuricemia, and metabolic syndromes. Thus, relative insulin resistance, particularly at the level of liver and muscle and fat, is seen. Remember, if we were to talk about the angiopathy which happens in type 2 diabetes mellitus, here it's the hyperinsulinemia which has been implicated for that kind of condition. And there are other hyperglycemic hormones, such as the only hypoglycemic hormone which we were to notice in body is insulin. So the other hyperglycemic hormones, such as glucagon, etc., what they cause is they cause relative insulin deficiency, and because of which the beta cells lag behind. There are other two minor types of diabetes, that is type 3 diabetes and type 4 diabetes. Type 3 is MODY, that is maturity onset of diabetes of the young, and then you have gestational diabetes, which are so implied. So to summarize the whole content, whenever we say diabetes, it's usually the type 2 diabetes, and we always try to prefer to cure the type 2 diabetes, and mostly the drugs which we read are going to be regarding to the type 2 diabetes. Alright, if you were to speak about the approaches to the drug therapy in type 2 diabetes mellitus, we have two ways of doing it. One is by increasing insulin, and second is by decreasing the insulin resistance itself. But there are some set of limitations for this. Once we are increasing the insulin, invariably we'll have multiple conditions of hypoglycemia, and also the fact that we'll have to give multiple daily injections. Well, these limitations are except for DPP-4 and GLP-1 agonists. Then we have weight gain. Of course, the person will gain weight. And then we have atherosclerosis, which is due to hyperinsulinemia. Then, as we were to talk about decreasing the diabetes or controlling diabetes by decreasing the insulin resistance, here the problem is that we will not be able to achieve normoglycemia, and this will happen in a lot of patients, and that would happen mainly in patients with severe or moderate cases of diabetes. Now let's first talk about insulin. And insulin firstly is classified as rapidly acting insulin. Here that would be rapidly acting insulin, which is an analog. Most of them are amino acids. So the mnemonic for this is going to be, hey listen pro, as a part of routine, rapidly apply glue within 15 minutes. Right? The mnemonic again is rapidly acting, hey listen pro, as a part of routine, rapidly apply glue within 15 minutes. Right? Here this listen pro will remind us of rapidly acting lispro. As a part would remind us of aspart. Then this is a rapidly type of insulin, rapidly acting insulin. And glue would remind us of glulysin. And 15 minutes would remind us of the fact that we have to take this insulin before 15 minutes of food. Then we have the short-acting insulins. The regular insulin is the short-acting insulin, and it is taken 1 hour before food. Then we have the intermediate insulin. The mnemonic for this is going to be, in the intermediate hotel of isophane, zinkin, I walked around 2 to 3 times a day. Right? In the intermediate hotel of isophane, zinkin, I walked around 2 to 3 times a day. So this would remind us of the fact that it's intermediate type of insulin. Isophane would remind us of the name isophane zinc insulin, and we have to take this 2 to 3 times a day. And then lastly we have the long acting insulins. The mnemonic for this is going to be dete mir ko large long. Right? Dete mir ko large long. So the mnemonic, the drugs in this condition are detemir and glargine. Right? The glargine can be condensed to large, and detemir can be written as detemir. Right? Why are they acting for a longer time is because they have increased plasma binding capacity. Right? They have larger binding capacity to the plasma. Having said that, let's quickly look into the oral anti-diabetic drugs. First, we have the increased insulin secretion. Then we have decreased insulin resistance, and then we have some other drugs. These are the miscellaneous drugs. First, increasing insulin secretion. This is more of like type 1 type of diabetes, and we have two mainstay of drugs or main methodologies of doing it. One is the DPP-4 inhibitors. The other one is the potassium channel blockers. Right? In potassium channel blockers, we have two subclassification of drugs. One is sulfonylureas. The other one is meglitinides. Right? In sulfonylureas, I want you to remember the prefix gli and the suffix ide. The prefix gli and the suffix ide. The mnemonic for this is going to be Ben's classmates Pizzi, Clazi, Mepi. Ben's classmates Pizzi, Clazi, Mepi. So gli is going to be glibenclamide. Class would remind us of gliclazide. Then we have glipizide. Then we have glimepiride, then we have glibenclamide, then we have glipizide, then we have gliclazide, and then we also have tolbutamide, right? Then secondly, we have the second class of drugs which are still under potassium channel blockers. We have meglitinides. So the mnemonic for this is going to be NEAT or REPA. NEAT or REPA. REPA would be reminding us of real estate professional assistant, but yeah, the glinide is going to come down as the suffix. So it's going to be nataglinide and repaglinide. Then as we go ahead of increasing the insulin secretion with DPP4 inhibitors. So for this, the mnemonic I want you to remember is Sita along Lena in the wild does DPP. Sita along Lena in the wild does DPP. The suffix you would be adding is going to be agliptin. So it's going to be sitagliptin, alogliptin, linagliptin, wildagliptin, right? These are the DPP4 inhibitors. Then we have decreasing the insulin resistance. This is more of like type 2 diabetes approach, right? In this we have two mainstay of drugs, which is the biguanides. The drug is metformin, and then we have thiazolidinidione. Sorry again, it's thiazolidinidione, right? For this we have the drug called as pioglitazone, right? We'll be talking about the mechanisms a bit later. Then we have the miscellaneous drugs. In miscellaneous drugs, we have alpha glucosidase inhibitors. In that, we have acarbose, miglitol, and voglibose. The mnemonic you could remember is alpha glucosidase ide akaralli, oglibose, don't inhibit it. Right? Alpha glucosidase ide akaralli, oglibose, don't inhibit it. Right? Then we have amylin analogs. In that, you have pramlintide, then we have pramlintide. Then we have dopamine D2 agonists. In that you have bromocriptine, and then we have SGLT2 inhibitors, that is dapagliflozin, right? We have dapagliflozin. Diving straight into how the GLP-1 receptor agonists act, the drugs which we have to remember here are exenatide, liraglutide, albiglutide, dulaglutide. So how they act is, they are basically incretins. So what they do is they act upon the stomach, and they basically cause increased satiety, right? And they delay the gastric emptying and thus slow down the glucose absorption. But what they do is they act upon the beta cells and increase the insulin and amylin secretion, and act upon the alpha cells to decrease the glucagon secretion, right? And this will again increase the satiety. Then what it also does is incretin system itself increases the beta cell health, and it decreases the islet cell apoptosis. So this is used in the therapy of type 2 diabetes mellitus, right? Having said that, we have known the drugs, that is liraglutide, albiglutide. Another important point is another incretin or GLP-1 like substance is GIP. GIP is glucose dependent insulinotropic peptide. Focusing on the side effects of GLP-1 related drugs, most of the drugs you can always remember except for few of the drugs, right? They'll cause hypoglycemia. We already spoke about them, the DPP4 inhibitors, right? Most of the drugs which are given for the treatment of diabetes would cause hypoglycemia. So the first one is, this is the side effect of the GLP-1 related drugs. Then we have nausea and vomiting. Then we have weight loss. Then we have pancreatitis. Now pancreatitis is due to the continuous stimulation of the pancreas. Focusing on sulfonylureas, the mechanism of action is pretty simple.